Hello, everybody. This is Matt, and I just wanted to quickly let you know this is our second of 3 recap episodes that we recorded at the American College of Physicians Internal Medicine Meeting 2019 in Philadelphia at the Pennsylvania Convention Center. What we did for these, we got our whole big team together. There were 10 of us there. We all pulled together our favorite pearls. We invited a special guest for each episode, and we just kind of let it roll. These episodes are not very heavily produced, very little editing. They don't have show notes along with them. We do try to cite the source or at least a session from ACP where we got these facts from. But we will be back in about 2 weeks' time with our normal fully produced episodes. Some things we have coming down the pike are BPH, HFpEF, heart disease in women, anaphylaxis, DVT, lots of great content. So please enjoy this episode, and we will see you back in about 2 weeks' time with our traditional full-length episodes.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity aside from possibly Cash Like More Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders.
Hi, Matt. How you doing?
We've taken Stuart's microphone away, literally. He's sharing one with me because we have a huge team recording here. Most of us are sleep deprived and very delirious. Paul and I learned today that is not good for you.
Right, we're getting dumber and meaner and fatter just as the day progresses.
Yeah.
And dying. Yeah.
So we're at ACP. As you can hear, I'm with Stuart and Paul. Stuart's yelling from a mountaintop. And with us is our good friend, Alia Chisty, returning from, I think it's been like 120 episodes-ish, maybe 130.
120.
Hi, guys. Happy to be here.
Thank you for taking some time out of like your busy conference schedule to come and I don't know, do whatever this insanity is that we're about to do here.
I get to hang out with you guys. This is the best.
Yes. All right. So we have some people that are actually going to go do more learning. So we should get right to it. But maybe Paul can tell them what we're gonna somewhat what we're gonna do today.
Sure. Rather than the usual experts, it's us, which is fine because we're smart people. So we're just going to recap a lot of the clinical pearls and sort of high points from the conference sessions that we attended here at ACP's 2019 conference. So a bunch of us went to a bunch of things. We have a bunch of knowledge bombs to drop on you. That sounds awful.
I think we should just go. Well, why don't we start with Alia? Why don't you start with a pearl? If you look like you're not ready, so I can call. We got a whole team here.
Just palpable panic.
How about you go next? Let's bring Molly up. Let's bring Molly up here.
Thank you, Molly.
Molly has a ton of good stuff.
All right, happy to join. Okay, so I attended a few lectures today. They were all great. So I'm going to start with one, some pearls from new drugs with Dr. Gerald Smetana. So the first one is there's a new medication that is approved this year, so we'll be seeing it more coming out for influenza. It's called baloxavir. It's pretty similar clinically to oseltamivir, so it reduces the duration of flu by about 1 day. It's a little bit different in that it's a novel antiviral mechanism. So we have seen some resistance coming out to oseltamivir, so perhaps this will become more common. It's just a single dose, so a little more convenient for patients to take. It is more expensive, of course, $157 as compared to about $50 for a course of oseltamivir. So keep an eye out for baloxavir this fall. And then the other new medication, we're having some trouble saying, solriamfetol.
Solriamfetol.
Let's hear that.
Solriamfetol.
Thank you, Google.
Excellent. All right, we got some solriamfetol. So this one is approved for daytime sleepiness associated with obstructive sleep apnea. So we know that about 10% of patients with obstructive sleep apnea who are as optimally treated as they can be with CPAP are still symptomatic, and some patients just can't tolerate CPAP. Women tend to be more symptomatic, younger patients, and then those with general poor health or depression tend to have continued symptoms with OSA. And so this medication is a novel reuptake inhibitor of dopamine and norepinephrine. It's possibly a little bit more effective than our currently approved medication for sleepiness with OSA, which is modafinil and armodafinil. It is not quite as stimulating, but does still have some concern about stimulant potential, so it will be a controlled medication.
Can I ask Molly or anyone else, are you using modafinil?
Personally? No, I don't use a lot of modafinil for my patients, but if they have concomitant sleep apnea and depression, I would use Wellbutrin, which essentially has the same, it's a little bit of more of a dirtier medication than solriamfetol, but does have some of the same adverse events. I mean, it's stimulating. It's actually used off-label for ADHD as well. So I wonder if is it more effective than, say, Wellbutrin or, I'm sorry, not Wellbutrin, bupropion?
Bupropion is not approved.
Illbutrin.
Sleepiness with OSA.
This is going to have the same issues because, this medication will have the same issues because it's a dopamine reuptake inhibitor. So all the Illbutrin issues with bupropion are probably going to be the same for solriamfetol.
We will have to see. All right. The next talk I wanted to highlight a few pearls from was Drug Allergies with Dr. John Kelso. So he highlighted the fact that only 5 to 10% of patients who say they have a penicillin allergy are actually truly penicillin allergic. So about 95% of our pen allergic patients can actually take penicillin safely. And we know that being labeled with a penicillin allergy leads patients to be treated with less effective or antibiotics that have more side effects. So this is important to think about.
Yeah, that was...
No, go ahead.
That was the prior episode. Netta Freja was telling us that she basically, like, there's increased MRSA, increased C. diff risk if you are labeled with a penicillin allergy, and she herself was probably mislabeled and was like getting tested. So get yourself tested.
So we can just test other antibiotics, right?
We cannot test other antibiotics. Yeah. So if you have a patient who has a good story for a penicillin allergy, you can send them to an allergist for a skin prick test. We don't really have reliable testing for other antibiotics. So if the skin prick is positive for other antibiotics, that's somewhat reliable that they probably do have an allergy. But if it's negative, it's not reliable. So it's not often done. The other thing to keep in mind is that 98% of truly penicillin allergic patients can tolerate cephalosporins. So especially if someone has a distant history of a kind of a mild reaction, so maybe just hives, we can feel very safe giving an oral cephalosporin. We might want to be a little careful if someone had a recent severe penicillin allergy and would probably want to avoid IV cephalosporins. And then from Dr. Rebecca Hutchinson, she gave a talk on palliative care in non-cancer patients. She brought up the fact that we spend a lot of time in medical education talking about diagnosis and less on prognostication. And it can be really important for our patients to be able to understand their prognosis and for us to be able to recommend treatments if we understand kind of what their trajectory is. So just something to think about. We can try to learn more about.
Yeah, so the Jerry Powell did an episode on that, which was, I don't know if we'll have show notes for this, but look at the Jerry Powell podcast.
There are not going to be show notes for this.
There won't be show notes, I can tell you that. Yeah, we're going to release this pretty quickly, so there won't be show notes, but Jerry Powell did a podcast on prognostication, so you can look that up.
Cool. And then a treatment that's often recommended by palliative care doctors for dyspnea is to have a fan blowing air in your face. And
I'm sorry, we're going to say apply a fan.
Keep it simple, yeah.
You're going to say apply a fan.
And so there actually was a randomized control trial published on this in the Journal of Pain and Symptom Management just this past year. And it showed that blowing air in your face does actually help reduce dyspnea more than blowing it on your legs. And then another study she highlighted was the one that we have discussed in a prior Hotcakes episode from the Annals of Emergency Medicine in 2018 about isopropyl alcohol smelling to reduce nausea. So basically just an alcohol pad under the nose helps reduce nausea within 30 minutes.
Yeah, I've seen patients I think it was the PACU, they were putting them underneath the nasal cannula, like one on each side. I was like, oh, that's an interesting delivery system for that.
I guess that works, yeah.
Yeah.
Well, those are all mine. I don't know who's up next.
Those are fantastic. Thank you, Molly. I think Alia's up next. If it's, are you ready now?
I feel ready. Thank you for that.
Okay, let's go.
So I'd actually like to share a couple of clinical pearls I learned from the Clinical Pearls Infectious Disease and Oncology session. It was moderated by John Bundrick, and our two panelists were Randall Edson and Andrea Weiner Hendrickson. And one of the cases that I really learned about that I realized that maybe I've seen this and didn't really recognize it when I saw it in the hospital. It was a case around a 68-year-old woman. She'd had multiple syncopal episodes, was admitted with a femoral fracture, and has a history of squamous cell carcinoma of the neck, status post chemo and radiation. And there was some concerns around maybe she had some VTAC, some abnormal electrolytes. And this was actually thought to be a side effect of her chemotherapy, that she had something called renal magnesium wasting. And that can be caused from multiple chemotherapy agents, including platins, ifosfamides, and even the monoclonal antibodies, which are some of our newer agents. And that it can cause direct damage to the renal tubules. And so you'll see a lot of hypokalemia and also some profound hypomagnesemia. And that can actually be a reason why they're having their, electrolyte disturbances, and then maybe their syncope. And so that was, to me, is something that I should be paying attention to.
That's great. I bet you I've missed cases of that too.
I'm sure I have.
Yeah. It kind of reminds me of like asking patients who have had radiation for breast cancer about like thinking of them as higher risk for heart disease, and then for chemo for neuropathy, taking that history as well. Until we learned that on the show way back when, I wasn't routinely asking that. So that's great to ask about. Stuart looks like he's like furiously looking things up here. So let me know if you find anything that you want to say. Okay. Keep going, Alia.
The other interesting pearl that I learned and would actually like to discuss with all of you guys was there seemed to be a little bit of discrepancy between the ID cases that were presented in the clinical pearls this morning, and then when I saw Dr. Gluckman with his curbside ID cases this afternoon around asymptomatic bacteria. And I mean, we know the only people that you treat with asymptomatic bacteria are pregnant women. And then something else that I just learned is, of course, people who are going to get some type of urologic procedure like a cystoscopy. But there's some data out there that patients who might be going for an orthopedic procedure, and if they get a UA and it's positive, what do you do with that? And so the case this morning was like, do not treat them. Just don't do it. And then Dr. Gluckman was like, well, you have to pick your battles. And so, I think that's interesting. The study he reviewed showed that that you can treat the patients with the asymptomatic bacteria prior to their orthopedic procedure, and if they have some type of complication of their joint, that the bacteria that grows from that joint is actually not the same as the urinary organism that was treated.
Now, aren't all patients going for an orthopedic procedure, at least at our institution? They're all getting cefazolin anyways, right? So it's like, why even, are you just going to change that to something else at that point? Or are you going to keep it on cefazolin and just say, whatever?
Sure, go to the fluoroquinolone. I think it's the right choice.
Yeah, I mean, the Dr. Finucane, who was on our show talking about asymptomatic bacteriuria, the study, he wrote this article, Requiem, I can't remember it's Requiem for a Heavyweight. And it's about urinary tract infections, in air quotes, as he likes to say it. But for asymptomatic bacteriuria, when they looked at those patients in the orthopedic study, it was felt to be, the conclusion was it's a marker of morbidity. So it's kind of like low albumin. There's not that much you can do about it. It's just a marker of morbidity, and those patients are going to have worse outcomes, one of which is probably prosthetic joint infection. Alia, anything else?
I love to share the stage with the
table. Let's bring in Justin Lee Burke. Justin, I think you need to. I think that mic is for your 6'2" stature. I don't think that mic.
Defensive stance. Straight. I'll work one in by the end. You guys didn't like my fun guy joke, and that was kind of the best I had. But so the first one I went to was Things We Do for No Reason. Talk essentially by Lenny Feldman, Dr. Lenny Feldman. He's been on the show before, and it was basically performance. It was standing room only in one of the bigger rooms. There's a lot of laughs, a lot of gasps, a lot of emotional roller coasters as he went through some of the evidence. We won't go into them too much, but some of the brief ones was essentially that there's good evidence that we don't need to be treating hypertensive urgency. We did an episode on that previously. No need to ever use prealbumin, and no need to ever use ammonia. He talked a little bit about some other things, but those were kind of the big takeaways, I think, that are easiest to summarize. Sure, you want to come join me for we'll talk about some of the GI updates because there was a lot of great. I'll turn over the celiac for you. No, this is going to be perfect. Okay. This is going to be our shtick. So first, there was a great review of the 2017 American College of Gastroenterology treatment plan for generalized dyspepsia or epigastric pain for about a month. Basically, the 3-step process. If you are over the age of 60 and have dyspepsia, you should get immediate EGD to rule out gastric cancer. If you are under the age of 60, you should immediately get an H. pylori stool antigen or breath test, just because the number needed to treat for symptomatic H. pylori infection was about 7. Stuart, you like number needed to treat, right?
Oh, yeah. I got a number needed to treat for you. A number needed to treat of 2 for duodenal ulcers.
That's right. If you have a duodenal ulcer, number needed to treat is 2. Gastric ulcer number needed to treat is 3, so very low number needed to treat. If you treat the H. pylori, or if the H. pylori test is negative, you can then go to the next step in the algorithm, which is just an anti-secretory treatment, which there's some evidence that H2 blockers are equally effective as PPI. So you just go to an H2 blocker.
I wanted to clarify the dyspepsia over 60, regardless of if they've been treated with a PPI. I feel like I was taught initially, like, treat with PPI for 6 weeks. If it doesn't get better, then you would proceed to EGD. But they were saying proceed, do not pass go, do not collect, just go straight to the.
That was the big takeaway.
Okay.
That was what I put in the infographic that's on Twitter today. So now it's kind of finalized and cemented.
Now it's canon.
But this is great. If that's wrong, someone can write in and we can have kind of a crowdsourced thing.
Publication peer review.
Beautiful. Yeah, this is what it's all about.
This is what we live for.
This is what it's all about. Thank you, Matt. On the topic of H. pylori, there was also some discussion on the Houston consensus. 3 of the presenters were all from Texas and then presented on the Houston consensus. So a big Texas presentation in the GI talk.
What was the Houston consensus?
The Houston consensus was a Delphi study where they looked at a lot of GI experts on who to treat, how to treat, and when to treat.
But only from Texas.
You had to be from Texas to be included. No, it was experts from all over the nation. It was a really big study. So who should be treated? All patients with ulcers or uninvestigated dyspepsia. But also there was a grade B recommendation for any patient with ITP, immunothrombocytic purpura. Nope. Immune thrombocytopenic purpura, because it's associated with H. pylori infection. So there's a strong agreement to treat. And then any first-generation immigrants from high prevalent areas or those who have families with active infection should also be treated or also tested. Tested is through biopsy, urea breath test, or stool antigen. It is okay to be on an H2 blocker or an acid, but if you're on a PPI, thank you, Stuart, the PPI has to be stopped 4 weeks before any testing. How about celiac disease? Do you guys have any questions, Matt? About
I think I would like to know how much bread can I eat if I have celiac disease?
Phenomenal question.
I got you. I got you. Very interesting. Even 1/40th of a slice of bread can show histological evidence of celiac. So if you have celiac or if you have a patient of celiac, it is pretty hard to get away with that. Whether that correlates to symptom, if 1/40th of a slice of bread correlates to symptoms, I don't know, but histologically it's been proven. Justin, why don't we do like a myth busting?
I love it.
I'm going to ask you a question and you're going to tell me yes or no.
I'm going to bust it or let it go.
Yeah.
Beautiful. Here we go.
How about that? Okay. So do patients with celiac have to be European?
Phenomenal question. It is not. It is a global disease that the global burden of disease is across all countries.
Okay, yeah. Particularly being Indian, actually the case that they used was of an Indian person, and they had a wonderful map of the world, and relatively the higher prevalence is actually Northern Indians, he was saying.
Yeah, unbelievable. Fun fact. That's a great pearl.
All right. Justin.
Yes.
Do you think patients with celiac are usually underweight?
Phenomenal question. They don't always have to be underweight. They can be of any weight and still have celiac disease, right?
Yeah. So,
amazing.
So don't, if your overweight patient has anemia or other symptoms, do not overlook celiac as a possible cause.
That's right.
Justin, do you think that patients with celiac is more of a pediatric thing and adults can't newly present with it?
Shreya, great question. It can come in pediatrics, but you can also have what's called the adolescent honeymoon period, where it will go away and you have no symptoms, and then it can represent later on in life. So an older person can also have their first presentation of celiac disease.
What are the other myths to bust? Those are my 3 big ones.
How about if a patient just starts eating a gluten-free diet and still seems to have symptoms, does that mean that they don't have celiac disease?
No, because there's 10% of patients with celiac who are quote-unquote non-responders. So be on the lookout for that.
Amazing.
Cool.
A lot of people have celiac disease, a prevalence of 1%, which, Matt, as you'll recall, is the same as ankylosing spondylitis. And most patients don't know that they have it. So there's another thing to add to your list.
I wonder if every day we could drop in ankylosing spondylitis.
It's going to be the new jump rope. I think that's all we have for you today, guys. Any other?
Okay, let's bring up Emmy and get some more pearls here. You have ID pearls for us today, Emmy?
Yes. Readjusting the mic. I'm not 6 feet here. So first up, I went to an ID update from George Karam from LSU. He shared the Marino Trial, which was a JAMA trial back in 2018. It was patients who came in with E. coli or Klebsiella resistant to third-generation cephalosporin. So these are your ESBLs, and were randomized to get either Piptazo or Meropenem. Now, the 30-day mortality rate was 12% in the Piptazo group and 4% in the Meropenem group. A lot of these people up front, they weren't sure what they had going in, so there was there was some cross in the trial between the two, but it does kind of have us thinking when a really sick patient comes in, we classically use our Vanc Piptazo, but maybe we should be reaching for the carbapenems instead.
Did they caveat this is with people who have a known risk for ESBL, or just anyone that's super sick?
Anyone who was diagnosed with ESBL. So they previously had gotten different medications before the randomization. But even after the randomization and moving forward, the effect was still pretty different.
Did they mention what the attributable risk was for seizure?
No, they did not go into that. Yeah. I will say they did also check at 30 days for C. diff and resistance, and there was no difference between the groups. So for those of you worrying about using a stronger antibiotic, there wasn't much risk at 30 days. So something to think about. Next up is fluoroquinolones. I know those are Matt's favorite drugs to use.
Yeah, they're safe.
Yeah,
we love them.
safe.
First line for rhinitis, cystitis, whatever.
Bronchitis, all of it. All the itises.
Yeah, so they went through some FDA updates in the past year. In July, they talked about dysglycemia, which is both hypo or hyperglycemia, and also mental health side effects. And these go as far as people having delirium or coma. So not just mild there. And then also in December, the FDA said that they are risk for the rare but serious complication of aortic dissection. So something to, be aware for your Marfan's patients.
I don't quite know what to do with that, Paul.
So as you're lying there on the ground after your Achilles tendon's ruptured, and you're like, no, I'm having crushing chest pain that's radiating to my back. Like this.
Ouch.
Yes. Also from the ID talk, the Partner 2 trial abstract is out. And the bottom line of that is U equals U. Now, do you guys know U equals U?
Yes. I do because the
equals untransmissible.
Yes.
Yeah.
Also known as treatment as prevention.
And Paul Sachs has written about this on his HIV and ID observations blog, which is great. And that can't be said enough, I think.
Yep. So get those viral loads down. What happened in a study with MSM, this was the first major study in MSM populations where there were 75,000 condomless sex acts. There was no transmission of linked HIV, meaning that there was HIV transmission within the group, but no were phylogenetically related HIV cases.
Are you saying it was infidelity? Is that?
No comment.
Okay. It just wasn't the same virus their partner had.
Yes.
Got it.
That is correct. And then we went to an anaphylaxis talk today and actually had a great recording session with Dr. Olajumoke Faduba from UPenn. We took a great session away, but I wanted to share a few more pearls that we didn't make it into the session. She did mention about the seafood and iodinated contrast reaction, and that is not a thing. Now, the reaction to seafood is to the tropomycin protein, not to the iodine in contrast. So there is no relationship between the two. Now, the caveat is people who are allergic to seafood are more likely to be allergic to anything, ergo more likely to have a contrast reaction, but there's no special things that you have to do for your seafood allergy patients needing a CAT scan.
And she mentioned if the seafood was an IgE mediated or a non-IgE mediated?
I believe so. She didn't mention it, but I believe that's IgE, whereas the contrast is a non-IgE mediated reaction.
She was saying with the seafood, you get itching as well. So mucocutaneous involvement plus pruritus.
Yep, those are IgE reactions, sounds like. Could be.
Story checks out.
Yeah.
Strong work, everyone.
Yep.
Yeah.
High fives all around.
Yes. Another thing that we can feel good about is the multiple studies on eggs and flu shots. So there is, and the CDC came out strong on this, saying that you can give any flu shot to anyone with an egg allergy. So
Fantastic.
No need for monitoring. And when people do have anaphylaxis, lay them supine, and your pregnant patients should be on the left side, and that's to relieve the pressure off the IVC. Just another thing to think about.
Yeah, I like how, and she was telling them that they should, an IM injection on the lateral thigh through the pants is the correct way to give the epi. Don't take time trying to pull down your trousers to give. Yeah, just go straight through. And
no Pulp Fiction style administration.
And the IM is better, and you hold it in for 10 seconds. Because there's different formulations, but if you hold it in for 10 seconds, that should get all the medicine. And there's plenty more in that. We're going to release a full episode on that. So, all right.
Like, from the pen, when you put in insulin, you got to hold it in for 10 seconds.
Got to hold it in. I did not know that. I don't counsel patients on giving insulin. I probably should know that.
Just give them the pen. Go with God. Good luck.
Well, other people.
See you back when your diabetes is better. Yeah.
No. Yeah. Okay. I'm a terrible doctor. Cyrus the Younger, let's get you up here. Cyrus, I think you're going to need to adjust the mic. Your frame is slightly bigger than Emi Okamoto, so.
Yes, unless she's very, very dense, in which case she maybe has a pound or two on me. Okay. Very unlikely. The session that I kind of went to and wanted to talk about was actually given by Dr. David Winchester out of the University of Florida College of Medicine. He mentioned that the negative predictive value for a coronary CT is 99%, which I think is awesome. But then the positive predictive value is not so great. It's like maybe 50 to 70%. And the reason being is that we can't really, with the current coronary CTs, can't really assess severity of that lesion very well. So you may be able to kind of say, yes, there is something, but then the next step is you send them for left heart cath. And so kind of tipped his cap a little bit towards the end of that statement by turning us on to the fact that over in California, there is a research group that is kind of looking at their coronary CTs and running them through this kind of supercomputer-driven algorithm. And they're actually able to look at that stenotic lesion and calculate an estimated fractional flow reserve, or FFR, based upon the kind of contrast hemodynamics in that at that stenotic point. So super cool, great way to get some data without actually inserting a catheter.
Hey, Cyrus, I have a question for you.
Yes, Stuart.
So why is it difficult for some professors to get hired?
Oh boy. Well, Stuart, I haven't the faintest.
Because they have a high tenure risk score.
Oh my gosh. Okay. All right. I'll buy it. High tenure risk score. Very good.
I think I still remember my comment. Well done, Stuart. That is really exciting. The fractional flow reserve, at least in concept, I think it's really exciting. So the fractional flow reserve is like in an actual coronary angiography where they sort of try to measure the flow across a lesion and determine if it's significant hemodynamically, right?
Exactly, right.
And if it's likely to be caused. So if they could do this non-invasively, I mean, that's almost like I don't know what you would call it, holy grail of
of non-invasive.
I'm sure if you're an interventionalist, you're not going to love that.
The only problem with that is that if we were to adopt that, then the meme that says that the outside hospital can perform casts for everything would no longer apply.
And that's a great meme too.
I know
so that would really stink.
Yeah, it would.
But I imagine patients would probably benefit more than that. Than the death of that meme would kind of impact the general community. So probably okay. But I think, it definitely, Matt, your point's very, very important because I think it puts another tool in the toolbox for us as internists. And really then you're kind of looking at, okay, if they go to CAT, it's for PCI. It's not for, more diagnostics that may result in, just up-titrate your goal-directed medical therapy.
Kind of surprised, and maybe I'm misunderstanding, that Treya hasn't bum rushed the mic yet, because we actually just had a great recording today, because I feel like we're working to the assumption that so I think we're using the term CAD, and we're talking about sort of obstructive CAD, and actually I think it's sort of been reclassified as sort of ischemic heart disease,
sure,
and in many women and some men, not all of ACS is actually caused by obstructive coronary artery disease. So I'm less wildly enthusiastic about the FFR because I'm not sure it's going to be entirely that helpful.
It's a great
in
point.
That specific case.
Right. So probably as things get more specialized, we're going to be it's going to be more complicated, more.
Thank God, finally, not this boring cardiology stuff.
Cyrus, what else do you have for us? I think you had something. You had an app and maybe some radiation stuff.
Oh yeah, for sure. So Dr. Winchester also mentioned an app that can be used. So it's if you go onto the Google Play Store or the App Store on your iPhone and you search multimodality AUC for appropriate use criteria, you can. There's an app there that basically it kind of takes you through the thought process of determining what are and are not appropriate stress testing options for a particular patient. And so it kind of tells you this one's a great test, this one's maybe not so great, and this one you shouldn't do. So I think it's a great thing. Like if you're sitting down with a patient who's kind of telling you a little bit of a story that's concerning, and you're thinking maybe you do need to stress this person, it's a great way to have the options and then even kind of turn it around and show it as a visual aid to your patient. Be like, so this is why I'm not, I mean, I know you heard about the heart cath, but this is why I'm not sending you for a heart cath. It's really not something that's recommended. It's expensive. It has risks, etc. So I think it could be a really powerful tool. And it's produced by Astellas, which is a pharmaceutical company. But I think the data, I believe, draws from some literature out of the ACC/AHA on stress testing. So
this, I don't know about you, Paul, but this is making me nervous about all the data is just going to drive everything, and it's it's all smarter than we are, and we're just gonna. Is this an existential crisis?
No, it's fine
for doctors.
We'll have guidelines. Part of the talk was guidelines actually narrow some of the gender bias that's inherent in sort of treating CAD between men and women, and also that there's this great quote about guidelines make good doctors great doctors. So that's what guidelines exist for. So I think that we'll have some sort of guidance. We're not going to be out there, and then we can always refer, I guess, if we have to.
Yeah,
for sure. I do, a couple other relatively quick ones. So one thing that Dr. Winchester talked about is kind of interesting, the dichotomy between the UK guidelines for stress testing and then the American guidelines, or like the ACC/AHA guidelines. So in the ACC/AHA guidelines, there kind of still is a patient population for whom a plain old exercise stress test would be recommended. And those are going to be like your kind of younger, lower risk, interpretable EKG folks that, maybe coming in with some chest pain that you're not particularly convinced about. So that being said, in the European guidelines, like the UK NICE guidelines, they don't have really any stress modality that they support where there is no imaging associated with it. So you see a lot more kind of stress echo, the myocardial perfusion studies, whether it's pharmacologic stress or actual treadmill stress. So that's kind of like, I thought that was interesting, and there was maybe some thought that collectively we're going to move in that direction just because the imaging can be very useful, and there are obviously limitations without having the imaging, but more to come on that.
The whole nuclear medicine stress testing, that is a huge amount of radiation. So I think that's the concern. Like you see, and the younger the patient is, the more time that radiation has to grow into something bad. Like if they're 75 years old, give Give them a nuclear, give them a nuclear stress test every year.
Sure.
Yeah.
40, they end up with an extra appendage.
They've had their exposures. Just yeah. Down.
And the caveat, Paul and I are both, we're sleep deprived. Everyone, actually, the whole team is. We were out late last night, and our the sleep deprived lecture, they told us I'm basically drunk right now, so I can't be held responsible for anything I'm saying.
It's outstanding. That's good. That's good.
You're doing great, buddy. Let's go for a drive.
And a drink. So thank you for that. The last kind of thing that I wanted to touch on is actually there are some interesting strategies which I had never heard of to kind of mitigate the radiation exposure in your patients. And so that actually would require you or your team to kind of have a discussion with cardiology or the cardiology techs that are kind of running the show. But for both coronary CT and for the myocardial perfusion studies, there are certain things you can do. So the way in which the coronary CT is gated and the way the protocol is actually run for that particular study. Basically with the coronary CTs, the way that they're protocoled, you can have kind of more or less exposure to radiation based on whether it's using like a predictive model in conjunction with the heart rhythm that's kind of being monitored versus if it's kind of just recording. So depending on how that is set up, you can kind of be exposed to more or less radiation. And then something super cool with the myocardial perfusion studies is typically when we do those, at least at my institution, we'll get rest imaging and then stress imaging and then rest imaging to kind of see if there's a reversible defect. Well, what Dr. Winchester said is that you can actually shave off time, cost, and radiation exposure by just asking them to do the stress imaging first. Particularly in your patients that you're maybe not as convinced. Again, if you use that ASCVD trick and you kind of feel like they're low intermediate, but you're still getting the MPS for whatever reason, you can ask them to do the stress imaging first. And if there's no abnormality during stress, then you don't need to do anything else.
I like it.
Super cool.
Saves the patient the radiation.
Awesome,
right.
Guys. Thanks.
Thank you. Cyrus the Younger. Okay. Paul, Alia, you got anything before we get to the wrap up here?
Oh, can I do my NAFL fun fact?
Yeah, please.
I can't remember if we talked about it. I don't think we talked about this yesterday, but there's a great talk, non-alcoholic fatty liver disease and NASH. And, I still feel like we're kind of in limbo in terms of how to treat, but it's lifestyle modification primarily. So if it's diet, like just have them lose some weight, easier said than done. We know this, difficult to sustain. But the thing that was kind of fun is you can actually encourage them to do one thing positive, and that's actually drink coffee. So caffeinated drip coffee decreases the risk and progression of fibrosis. I don't think French press was checked.
Okay.
But tea does not work, soda does not work, decaf does not work. Keurig's probably okay.
Wonderful.
Bad for the environment.
Well, sure. But the world's on fire. It's going to be gone 20 years anyway, so go to town.
I have kids.
Oh, so sorry. But yeah, so it's nice because there's so many things that we tell the patients that you cannot do. So stop drinking alcohol and please exercise, and you can't eat salt and you can't eat this. So to be able to say one thing that you can do that's actually enjoyable, go ahead and drink some coffee. It's going to help you. I think is a nice thing to tell patients. So I enjoyed that, Pearl.
Excellent. Can I go over the syncope, or do you want to go in the wrap up?
I want to hear about syncope.
Syncope.
Stuart, you built this up now.
All of my. There we go. So a couple of clinical pearls from syncope that I thought were very useful. So we talked about this before, that in order to rule out syncope, rule in seizure, to look at the differences between two, we talked about lateral tongue biting being the most specific marker for seizure, although it's not present in most cases of seizure. What was interesting, though, was that incontinence was not helpful in actually diagnosing syncope versus seizure, because most patients with syncope have a history of incontinence. And so it didn't really help, right?
Good point.
And then, so we went from that and actually talking about the PESIT trial that came out a couple of years ago. We talked about this on our podcast, I think like episode 32, 33, something like that, syncope update trial. So, PESIT trial, about a quarter of patients are admitted to the hospital with syncope. Of those patients who are admitted to the hospital, 17% of those patients had a pulmonary embolism.
Right.
In the United States, 80% of patients presenting to the ED are admitted for syncope are admitted to the hospital. Of those patients in the United States who are admitted to the hospital, 1% of them have a diagnosed PE. Mm-hmm. Okay. Now, when you go back to the PESIT trial, 2/3 of those patients in the PESIT trial had a major pulmonary embolism that otherwise would have been diagnosed as a pulmonary embolism, right?
That's out of the 17% that were found to have PE.
Exactly. So
2/3 were obvious.
1/3 of them were essentially incidental, either subsegmental or asymptomatic. Those are the patients that we're saying that, hey, if you're admitted to the hospital in the United States with syncope, not admitted for pulmonary embolism, we're finding 1% of them have a pulmonary embolism. Okay, so we're over admitting, and the actual incidence for our over admitted patient population actually levels out to what you should have seen in the PESIT trial if you were to admit 80% of the patients who are admitted from the PESIT trial. When you compare this to Canada, 13% of patients who come to the ED in Canada are admitted for syncope. Okay, of those patients, 2.5% had a pulmonary embolism. So obviously, we're probably over-admitting in the United States, number one. Number two, that when you level those out, it's not really significantly different. And when you look at all the studies together, consider that after a structured workup, which includes obviously an EKG and an H&P prior admission, up to about 3% may still have an undiagnosed PE. So you still need to be on the lookout for it, but it's not necessarily something that was initially like the sky is falling for the PESIT trial.
Right.
What I did find concerning, though, what's the most common ECG finding for PE?
Normal sinus rhythm.
Yeah, normal sinus rhythm, right? So you're saying that the structured workup includes an EKG or ECG, when then the most common finding is normal sinus rhythm. Great, thanks. So the recommendation obviously was to do a well score in D-dimer and then just use clinical decision making from there. Okay, so when we're talking about the workup of syncope, all right, you can probably cut this out, but we
this is not being edited, right?
Normal neurologic examination, 0% yield for doing any kind of head imaging. So don't do it. For echocardiography, for all patients with syncope, 1% yield. Okay? So for all patients with syncope, if you got an echocardiogram, it costs $100,000 to diagnose one cardiac etiology for syncope. Not worth it. If you instead looked at patients with normal ECG, the yield was 0%, which is kind of funny, right? But if you suspected that they had CAD, the yield was 5-10%. So the actual cost to diagnose one cardiac syncope was anywhere from $35,000 to $100,000, depending on what the actual clinical context was. What I found interesting, though, was that when you look at diagnostic yield for carotid sinus massage, especially in an elderly patient who had an unexplained history, and had a suggestive history of cardiac disease, the diagnostic yield was 46% and actually found in etiology about half the time.
But do you remember when we talked about carotid sinus massage, you sequentially give firm pressure for like 5 seconds and it drops their systolic pressure by like 50 and they may have bradycardia or like 10 seconds of asystole.
He's like,
10 seconds.
He said you need to listen very closely for a bruit first.
Yeah.
So that's issue number one. And issue number two was check their vital signs first, obviously.
Yeah, you might want to do it in the ER.
Probably.
Where it's actually like an
continuous monitoring.
ICU level care, continuous monitoring.
And then similarly for patients that have recurrent syncope, tilt table test had a diagnostic yield of 49%, which actually makes me kind of upset.
Those are very hard to get in my experience.
Yeah, very, very hard. All right, last one. Canadian syncope risk score. Is what was recommended. If you've never used it before, it's actually a very simple tool. Just a few questions. You can go on a MedCalc and find it, MDCalc, and assesses the 30-day risk and assists with clinical decision-making, whether or not to admit or not. All right, that's all I have.
Any final pearls? We have one more recap tomorrow, so we can put some stuff in there. Alia, anything? I'll give you the last word.
Can I just say smoking is bad? I just like to say that, just to add that in.
Even if I'm like already dying from cancer, I shouldn't just like keep going?
No, just don't do it.
Okay.
Even if you have cancer, even if you have, you are dying from cancer and you're getting some type of treatment, that treatment's not going to work. It's just not going to help you. It's not going to be better. Just don't do it.
Okay. All right. I always, whenever I think of that kind of thing, I think this is many of our listeners won't get this if they're younger than me, but the Grumpy Old Men movie, Burgess Meredith is like, his character eats a pound of bacon every day and chain smokes cigarettes, and he like dies on a park bench, like overlooking a lake at like age 100. And I'm just like, that's great. Good for this guy. This has been another episode of the Curbsiders.
Bringing you a little knowledge food for your brain hole.
Yummy.
I'm all thrown off. Get your show notes at thecurbsiders.com/podcast. Then sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox. There will be no show notes for this episode.
That's right. We're committed to providing you practice changing and high volume. Hold on.
Stuart's having a TIA.
You guys are all sleep deprived. It's okay.
Yeah, that's right. We're committed to providing you high value, practice changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show on iTunes or contact Matt personally at thecurbsiders@gmail.com. He will send you a reply at his leisure.
A special thanks to our videographer for this episode, Dr. Christopher Chu, and then to our whole team of correspondents who you've heard on air, and to our wonderful guest, Dr. Alia Chisty.
And to our social media team, Hannah R. Abrams on Twitter, Beth Garbatelli on Instagram, and Chris, the Chu Man Chu, on Facebook. Until next time, I'm tired.
And Cyrus Askin pinch hitting on Twitter for this conference at ACP. Thank you, Cyrus. I've been Dr. Matthew Frank Watto.
Alia Chisty.
Strong.
Thank you.
I remain Dr. Paul Nelson Williams. Thank you and goodbye.
Good night, Paul.